Let's talk about tetanus in this video. Tetanus is an acute disease which is manifested by skeletal muscle spasm and autonomic nervous system disturbance. It is caused by Clostridium tetani. It is found throughout the world, but more common where vaccination coverage is very low. In any setting, established tetanus is a very severe disease and has a very high mortality rate. CDC defines probable tetanus as an acute illness with muscle spasms or hypertonia in the absence of a more likely diagnosis. WHO defines neonatal tetanus as an illness occurring in a child who has normal ability to suck and cry in the first 2 days of life, but who loses this ability between day 3 and 28 of life and becomes rigid and has spasms. Maternal tetanus is defined by WHO as tetanus occurring during pregnancy or within 6 weeks after conclusion of pregnancy, whether with birth, miscarriage, or abortion. So all these three definitions are asked many times and it is very important to know them. So etiology is Clostridium tetani, which is an anaerobic, gram-positive and spore-forming organism. It has terminal spores as you can see here. Right? The spore is highly resilient, resist boiling and disinfectants. Tetanus is rare in the developed world. High risk group is elderly beyond 60 years of age, diabetes, IV drug abusers and incomplete vaccination or unvaccinated people. The pathogenesis, tetanus toxin, which is produced as a single 150 kilodalton protein. It is cleaved to produce a heavy and light chains linked by a disulfide bond and non-covalent forces. So it will produce two endotoxin. One is titanospasmin, which is more potent, and a titanolysin, which has no role in the pathogenesis of tetanus disease. So this you have to very importantly remember that it gets split into a heavy and light chain linked by a disulfide bond and non-covalent forces. It has two exotoxins known as titanospasmin and titanolysin, out of which titanospasmin is potent and titanolysin has no role. So the tetanus toxin undergoes retrograde transport into the CNS. It is intra-axonally transported to motor nuclei of the cranial nerves and ventral horns of the spinal cord. The carboxy terminal of the heavy chain, previously I have told you that the toxin splits into heavy and light chain. So the heavy chain binds to the membrane components in presynaptic alpha motor terminals, nerve terminals, which results in toxin internalization and uptake into the nerves. So it is a wide spectrum, broadly divided into generalized and local. Local tetanus, only isolated areas of the body and only a small areas of the local muscle area spasm. If the cranial nerves are involved in local cephalic tetanus and pharyngeal or laryngeal muscles may spasm with consequent aspiration or airway obstruction, which is a poor prognosis. Generalized tetanus is muscles of the face and jaw are often affected first, presumably because of shorter distances of toxin must travel up to motor nerves to reach the presynaptic terminals. Neonates typically present with inability to suck. So this is Rhizus sardonicus. It is spasm of the facial muscles producing a grimacing facies. So this is a picture of opisthotonus, painful spasm of the neck, trunk and extremity producing bowing or arching of the back. So these are some pictures of local tetanus. Injury over the dorsum of the hand with flexion of the fingers sparing the thumb. Improvement of flexion after treatment with tetanus immunoglobulin and crystalline penicillin. There is spasm of the hand. This is known as local tetanus. The incubation period is 3 to 21 days, average of 10 days. Further, the injury side is from the central nervous system longer the incubation period, which means that farther the site from the CNS, longer is the incubation period. Neonatal tetanus, it is 4 to 14 days, averages of 7 days. So the signs and symptoms are trismus, that is locked jaw, which is the most common initial sign, muscle pain and stiffness, back pain, difficulty in swallowing, difficulty in feeding, especially in neonates, painful generalized muscle spasm, complete airway obstruction, laryngeal muscle involvement, respiratory failure, which is muscle spasm of the respiratory muscles and most common cause of death in tetanus, tendon avulsions and crush fractures reported, but they are very rare. The cardiovascular events, labile BP, rapid fluctuation from high to low, accompanied by tachycardia, bradycardia and heart block may also be seen. Autonomic involvement is evidenced by gastrointestinal stasis, sweating, increased tracheal secretions, and often acute high output renal failure. Autonomic disturbance is maximal by the second week. So this is an algorithm. Wound infection, multiplication by Clostridium tetani. There are no symptoms. Tetanus toxin uptake into nervous system. Cleavage in GABA inhibitory neurons. In 7 to 10 days, there is initial symptoms, muscle aches, trismus and myalgia. In further 48 to 72 hours, further toxin affects widespread disinhibition in motor and autonomic nervous system. So there is muscle spasm and local and generalized, cardiovascular instability, labile BP, tachy or bradycardia, pyrexia, increased respiratory and GI secretions. At 4 to 6 weeks, there is toxin degradation. So there is cessation of spasm, restoration of normal muscle tone, cardiovascular and autonomic control. Diagnosis is based on clinical findings. Culture of Clostridium tetani from a wound provides supportive evidence. Serum anti-tetanus immunoglobulin is measured by ELISA. PCR used for detection of tetanus toxin, but sensitivity is unknown. Entry wound should be identified, clean and debrided of necrotic material to remove the anaerobic foci of infection and prevent further toxin degradation. Ideally, patient should be nursed in calm, quiet environment because light and noise can trigger spasms. Metronidazole 400 mg rectally or 500 mg IV every 6 hourly for 7 days is preferred antibiotic therapy. An alternative is penicillin, 1 lakh to 2 lakh international units per kg per day. Although this drug is theoretically may exacerbate spasms and in one study was associated with increased mortality, failure to remove pockets of ongoing infection may result in recurrent or prolonged tetanus. Antitoxins given early in an attempt to deactivate any circulating tetanus toxin and prevents its uptake into the nervous system. Two preparations are available. One is human tetanus immunoglobulin and equine antitoxin. Tetanus immunoglobulin is the preparation of choice, less likely to be associated with anaphylactoid reactions. Single intramuscular dose 3000 to 5000 international units is given with a portion injected around the wound. Equine-derived antitoxin is available widely, used in low-income countries. After hypersensitivity testing is given, 10,000 to 20,000 international units as intramuscular injection as a single dose or in divided doses can be given. Complications during treatment are thrombophlebitis associated with diazepam injection, ventilator-associated pneumonia, central line infections, sepsis, DVT, and thromboembolism. So factors associated with poor prognosis in tetanus: adult age greater than 70 years, incubation period less than 7 days, short time from first symptom to admission, puerperial IV, post-surgery burn entry wound, period of onset less than 48 hours, heart rate more than 140 beats per minute, systolic blood pressure more than 140 mmHg, severe disease or spasm, temperature more than 38.5 degrees Celsius, younger age in neonatal tetanus. The poor prognostic signs are younger age or premature birth, incubation period less than 6 days, delay in hospital admission, low birth weight, and fever on admission. Conditions that mimic tetanus: strychnine poisoning, dystonic reactions to antidopaminergic drugs. Abdominal muscle rigidity is characteristically continuous in tetanus but is episodic in the latter two conditions. Cephalic tetanus can be confused with trismus of other etiologies such as oropharyngeal infection, hypocalcemia, and meningoencephalitis.